welcome to the Mental Health Policy Research Unit at UCL and King's. We're very pleased to be hosting with Andre Tomlin, the Mental Health, this afternoon's webinar on peer support and its role in mental health care in England. We've got a mixture of presentations from the Policy Research Unit and from some other presentations and commentary from some other national experts in this field. We've published one of the papers we're going to talk about, and two of the others are in preprint. This is on the Policy Research Unit's work on mental health peer support. And so we'll circulate those links to you. I've just realized I've failed to introduce myself, although my video does make it clear that I'm Sonia Johnson, and I'm a psychiatrist working at UCL, and I'm director of the policy research, the NIHR Policy Research Unit in mental health. Our role is to deliver evidence through short research projects or evidence synthesis to inform policy on mental health, particularly for the Department of Health and Social Care and NHS England. So one other thing just to let you know is if you have questions, I would recommend posting them in the chat. We'll keep an eye on the chat. We should be able to answer some questions immediately after the presentations if the speakers keep to time. If there are questions we don't have time for, then we've asked our speakers to keep an eye on the chat, and they or other members of the team will pick up the questions in the chat as the webinar goes on. So I think that's all that you need to know. We're delighted to see such a substantial audience here this afternoon for this. We hope that you'll also consider coming to our mental health question time if you're able to. That's in a week's time in the early evening at UCL, and we'll post links during this afternoon about how to sign up for that if you've not done so already. Okay, so I'm now going to hand over to my co-chair for this afternoon, Andrew Grundy, who's going to briefly explain to you why peer support, and then start introducing the speakers. Well, then I'll introduce the first speaker. So Andrew, over to you. Andrew's lead for lived experience research in the Policy Research Unit and deputy director of the unit.
Thanks, Sonia. Good afternoon, everyone. So in the last Mental Health Policy Research Unit, we had a team of 12 lived experience researchers involved in all of our projects. And I believe all 12 lived experience researchers were involved and invested in this particular part of our research program, because at the heart of peer support, obviously, is lived experience, the lived experience of mental distress, disorder, illness, however conceptualized, and how people who have had experience of mental distress can use that experience to come alongside others, to benefit others in what might be conceived as a peer-to-peer relationship. And some of our members had received peer support and brought insight into these relationships, their challenges, their benefits as recipients of peer support. Some have been in peer support roles and know firsthand the challenges of embedding these roles within multidisciplinary teams. And as lived experience researchers, we could all see the potential of peer support in mental health services, but we're also aware of the danger of it being co-opted or diluted in services. And we believe research into peer support is vital to understand its mechanisms, its benefits, and its limitations, within current service models. And we're thrilled to be presenting findings from our studies that have had lived experience involvement in their design and conduct from idea conception all the way through to dissemination. And so a big welcome to our event this afternoon.
Thank you, Andrew. And yeah, welcome to this from all of us. And great to see quite a few people who we've worked with or who've worked sometimes on this work in the audience as well. So I'm very pleased to introduce the first speakers. So we're having a presentation of an umbrella review, an attempt to review all the systematic reviews that have been published on peer support. And here to present it are the lead author on the review, Ruth Cooper, who's a former postdoc researcher with the Policy Research Unit in Mental Health, and Karen MACHIN, who is one of our lived experience researchers in both the first and the new Policy Research Unit. And she's also co-director of the Survivor Researcher Networker. She's has a great deal of expertise in delivering and training people in peer support. And she's also one of the authors of this review. So over to Ruth to start that presentation. Thank you.
Hey, thanks, Sonia. Thanks, everybody, for coming. So I'm Ruth, and Karen is also presenting with me. And we're presenting a umbrella review, which looked at what the research tells us about peer support for mental health. And as Sonia was saying, this was conducted as part of the NHR Policy Research Unit in Mental Health. So this is just our funding statement. So this is funded by the NAHR. And then I think Karen is going to talk you through this slide.
Just a little bit of background. I know that Andrew and Sonia have both introduced peer support and what it is. You know, it is a mutual, reciprocal, equal relationship amongst people who've experienced challenges of whatever kind. And peer support is very common and is something that we all draw on. And it's been of increasing interest to mental health services over the last 15 years, but particularly within the last 5 years with the response to the long-term plan in the NHS, and it has grown remarkably. It's recommended in policy guidance. You know, it is increasingly of interest, and including to researchers who have set out to understand what it is and how it can make a difference. And I'll hand over to Ruth to describe what we've done in terms of the research.
So there's been a lot of reviews of peer support conducted over the years. And so what we aimed to do was to summarize all the reviews that have been conducted to date. So we did this, as you can see from this figure on the right. So we start with individual studies, for example, studies where you'd be interviewed about your experiences of working in peer support. So these individual studies are then summarized in what we call a systematic review. And we call this a systematic review because we use methods that aim to find all the studies that have ever been conducted in the particular area we're looking at. So in a particular area of peer support. So we then summarized all these systematic reviews in an umbrella review. So an umbrella review is a review of all the systematic reviews of peer support. And we aim to answer the following research questions. So we wanted to look at what is the effectiveness of peer support for mental health, what influences the implementation of peer support, and what are the experiences of peer support in mental health. And so this review is published and it's really available. And I can put the link to it in the chat if that's not in there already. So I can do that after we've finished. So yeah, please do go and read the review. It's quite long and there's lots of detail in it. Okay, and so these are the steps we took to conduct the umbrella review. So to find the reviews, we searched 5 scientific databases where all the scientific papers are held. So for example, Medline and Embase. We used keywords for peer support when we searched in these databases. And then we selected relevant reviews, which reviewed pay peer support for children or adults with any mental health condition. And so we found 35 reviews which looked at this. These reviews included a large number of individual studies, so 426 individual studies, and each review included between 95 participants up to over 40,000 participants. So this was a big study. We then looked at the quality of these 35 reviews, and we found that the quality was generally quite low. So 97% of the reviews were low or critically low quality. We then extracted relevant data from these reviews, so data which looked at the effectiveness, implementation, and experiences of peer support. And we then synthesized this data to answer our research questions and wrote up our umbrella review. We've got a very detailed protocol, which is available online as well, which I can put in the chat after as well, if you're interested in the detail of the methods that we used. And then I'll just hand over to Karen to talk about our involvement of people with lived experience in this.
Thanks, Ruth. So in all of those many stages that Ruth just described, they all involved people from the lived experience working group. And Lizzie, who's here today, as well as myself, wrote a lived experience commentary for this particular study. These lived experience commentaries have been an innovation of the policy research unit, so I think they're worth a mention. That's where papers have a section that is written independently by people with lived experience. And I think these commentaries work particularly well when we've been involved in the study itself, and we can speak from that experience. We can include comments that we might make, but that don't have a clear place in that sort of standardized format of a journal article. In this study, Lizzie and I used the commentary to highlight that the methodology of the study meant that various elements could not be included, such as the unpaid peer supporters, because this study concentrates on paid peer supporters, and also that the review is of academic studies, which are consequently looking at peer support through a specific lens, which is likely to be different from how we might look at it with a lived experience perspective if we were to start from scratch. And clearly we weren't doing that. And that's not to negate the study itself. It is what it is. I always refer to this particular study as being a line in the sand in 2024, summarising the breadth of academic work that's in relation to these three questions. But a commentary allows us to be that critical friend, pointing to some of these issues. And our hope as a team is that by voicing some of these concerns, we might influence future research. Ruth.
Thank you. Okay, so we're just going to talk you through the results. So in terms of the first research question, so we looked at what is the effectiveness of peer support. So how helpful is peer support for the service users receiving it? So this was reported in 23 reviews, but I'm just going to report the results from the reviews which included meta-analysis. So this is where reviews look at whether peer support works better than what we call a control condition. And that could be, it's often usual care without peer support. And then this data is statistically analysed, and it's considered to be the best way to look at effectiveness. So overall findings were quite mixed. So that means that a lot of studies found peer support was helpful, but then others found it wasn't any better than the control condition. So in terms of where we found peer support could lead to improvements, so we found evidence that peer support could lead to improvements for people with depression, particularly perinatal depression. It could help people to recover. It could lead to improved self-efficacy, so a belief in somebody's ability to reach specific goals. It could lead to reduced feelings of stigma, such as self-stigma. And then we found quite mixed findings for these outcomes. So some studies found peer support led to improvements, but some found it wasn't better than control. So we found mixed findings for empowerment, quality of life for service users, service use, such as rates of rehospitalization, and other clinical outcomes, such as improvements in help seeking, and also hope. And we didn't find any consistent evidence for an effective peer support on other mental health symptoms other than depression. So, for example, overall symptoms. satisfaction. So, for example, satisfaction with care, relational outcomes such as social network supports, and people's functioning. Okay, I'm just going to hand over to Karen.
So the next part of this project, I mean, it was such a large project and a lot to report back, but this is, we divide ourselves into several teams. I wasn't specifically involved in this section, which is looking at the implementation of peer support. And we use the consolidated framework for implementation research. I've used that framework for many years as part of my own practice. So it was reassuring for me to see that the results from the academic papers reflected what I'd seen in practice for the last 15 years or so. This table that we've got on the screen is just a very brief summary of the sort of the detail that's in the paper. So I'd really encourage people to go and look at the paper. There's so much more in there. The CFIR uses these 5 factors. The innovation of peer support itself is well accepted. That top one. The second one is around that outer setting. Really emphasising there that national policy initiatives and funding. We've seen the incredible growth and interest and since funding for training in particular was provided nationally by NHS England. In practice, that's felt like the main driver, and that's there in that outer setting. The inner setting is the organisation or the team where peer support is being implemented. And here we recognise the importance of culture, the culture of the team or the organisation, to ensure that accepts and supports the introduction of peer support. The research mentions strong leadership at the highest level, that it recognising it can take one person to drive that interest in peer support. Whereas in practice, we might promote leadership at all levels to include the views of people who might use peer support and the people who might provide it, reflecting that emphasis on co-production, the importance of that. All individual people involved need to be supportive of peer support. I think that goes without saying, really, to promote that quality as well, about the skills and the ethics, as well as having some champions and thinking about recruitment practices so that the individuals are throughout the organisation, not just within that one particular team. And that final factor of the implementation process, we've found that that's the one that everyone wants to jump to, like, how do I do it? How do I get started on it? But I'd argue that those first 4 factors that we've described there are essential to build the scene for this particular one. The literature didn't say anything new to me about implementation, so it's really reassuring that emphasis that training needs to be provided for peer support workers, but also for the whole team. It's not just about the peer supporters, and that supervision should be provided for peer supporters. Ideally, I'd say by a senior peer support worker, so bringing that lived experience through to supervision. And everybody wants clear definitions, but I think we have to be mindful about maintaining the flexibility of the role. There is so much more detail in the paper, and I'd really encourage people just to go to that, really, because it's such a rich table within the article. If you go to the next slide, Kirsten, please. Oh, Ruth, sorry, you're up to the slides, aren't you? Sorry, got Kirsten in my head. So another element that we looked at with the experiences of peer support, and this was included in 11 reviews, and it showed that perspectives from a real different range of mixed samples. So that would include peer support workers, it would include their clients, the people using their service, and also other healthcare staff. Some people refer to that as the non-peer staff within the organisations. So that was in 11 of the reviews, and we reported it in 3 themes. So we've got 3 slides. They cover what the role can bring, which I'll talk about here, and then there's confusion over the role and the organisation challenges and impact, which we'll come to later. So this slide, talking about what the peer supporters can bring, highlights that peer supporters bring something different, and there is something around that authenticity of the lived experience that brings hope. It normalises and potentially demedicalises distressing experiences. It can bring an easier rapport and empathy, and peer supporters are fundamentally about recovery-oriented care. And that all impacts on the well-being of the peer support worker. Where it works well and peer support workers are valued, there's increased confidence and self-esteem. But there can be a flip side if it's not working as well, which can potentially impact on everyone's well-being, and that includes their colleagues and the people using their service. And there's also that concern, as raised in that one of the reports, that a sick label can stay with the peer support workers. That's not to undermine any of the many positives, and the differences that peer supporters can bring to the team can contribute to it. And I should perhaps also point out here that some of those elements we might question from a lived experience perspective. So, for example, I personally don't like the pressure to be a bridge or to be a role model, but that language doesn't sit comfortably for me personally. But we have to report what's actually in the reviews and what we've read in them. I'll hand over to Ruth to describe the other two themes.
Thanks. So our next theme was confusion over the peer support role. Within this we had made the main points of role ambiguity, boundaries, role conflict and professionalisation, and disclosure of peer status. So, for example, with role ambiguity, the peer support role could often be experienced as ambiguous, and this could be positive as it gave flexibility to define the role, but it could also lead peer support workers to feel confused, which could affect their confidence and could lead to some uncertainty and responsibilities towards clients. Some issues around boundaries came up. So, for example, where to draw the line between friend and service provider. And there could be some confusion over when to disclose. So some peer support workers felt vulnerable and could be reluctant to disclose about their lived experience, but disclosure could build trust with clients and could also educate mental health teams on alternative views. And then our last theme was looking at organisational challenges and impact. And so within this, we had various challenges for healthcare staff and organisations: low pay, high workloads, a lack of support and training, colleagues and stigma, and treatment models. So, for example, in terms of low pay, quite a lot of reviews talked about role dissatisfaction due to peer support role not being well paid, and this could suggest that the job was new, not valued, or that it was unclear. Some people talked about some of the reviews talked about a lack of support, training and supervision for peer support workers, which could mean that some peer support workers struggled to develop skills for their roles, such as working with service users with more complex needs than their own experiences. And colleagues and stigma. So some peer support workers talked about experiencing some negative staff attitudes. So, for example, not being invited to certain work events. It could lead to peer support workers experiencing self-stigma and feeling isolated. Okay, and then we'll just go on to our final slide, which just talks about the implications of our review.
It's 16 minutes, Ruth.
Oh, sorry. Yes, this is the last slide. So in terms of practice, so culture, hierarchical structure and staff acceptability of peer support can impact implementation. So structural and cultural change could be required for peer support to succeed. So, for example, ensuring a recovery-oriented care model is operating in the service. In terms of policy, so successful implementation of peer support requires a co-production approach, and peer support really needs to be adequately resourced, so adequately paid. People need to have appropriate office space and access to resources. And lastly, in terms of research, as peer support becomes more established, more kind of research is needed over time, and we need better definitions of peer support roles. So, for example, the type of interventions to deliver, and more lived experience involvement in peer support research is needed. So, for example, in setting research priorities in peer support. That's the end of the presentation. Thank you for listening.
Thank you very much. Very crisply and clearly done. Thank you. It's great. We've got in the chat, I think there's one question, which is from Vicky. Vicky, I don't know if you want to ask this in person.
Yeah, I'd be happy to.
Yeah, go for it.
If it makes sense. I was just thinking, given one of the earlier slides, if I understood correctly, the reviewers found that a lot of the studies that were included in the systematic review were of poor quality. And I just wondered, if so many of them were of poor quality, what impact that had on the ability to kind of extract any meaningful findings from them. I hope that makes sense as a question.
Yeah. So the way you quality score them it uses very, very stringent criteria. So the kind of main things the reviews got low quality on was things like not pre-registering the protocol, not justifying excluding individual studies, and not considering the quality of individual studies they were including when interpreting results. So these are like quite stringent things which are very specific to systematic reviews. I think the reviews are still contain a lot of very good information, and it was still very useful to summarize them. Yeah, and I think our kind of this quality scoring was in line with another umbrella review that was done in peer support. So yeah, I'd say that it's quite stringent, the criteria that you measure this quality on.
No, thank you. That's a really good response, Ruth. I didn't realise those were the aspects of the reviews that were of poorer quality. Thank you. That's really helpful.
And Simon, do you want to quickly ask your question that you put in the chat?
Sure. I was aware that quite a lot of the early trials of peer support working in the US where peers were essentially fulfilling similar roles to other people in community teams. So doing the same thing but being peers. So the comparison wasn't really finding any effect, but lots of trials were done in those kind of not really pure peer support roles, I guess. Did you notice any change in the quality of evidence or the outcomes over time as you went through the reviews, as the evidence progressed? Did it improve, or did there more effect?
I think that'll be really good to look at. We didn't look at changes over time, but I think that'll be really useful to look at. We were looking at where the individual studies were from before, weren't we, Karen? And a lot of them were from the US. So yeah, encompass this.
Great. We can continue with questions and comments in the chat if people would like to, but I'll hand over to Andrew to introduce the next speaker. Thank you very much.
Thanks, Ruth. Thanks, Karen, for a great presentation. For our next presentation, I'd like to introduce Una. Una is a postdoc mental health researcher and former researcher at the PRO, specialising in using lived experience voices to help improve our understanding of eating disorders. And Una's lead author on our peer support implementation paper. I'd like to introduce Lizzie, who's a lived experience researcher at the PRO, who's also received peer support and trained and worked as a peer support worker. And Una and Lizzie are going to present on peer support implementation, barriers and facilitators. Over to you.
Thank you so much, Andrew. That's a much nicer introduction than I would give myself, so I really appreciate that. And thank you so much for everyone who has come along. It's really amazing to see so many people interested in peer support, but also to see some familiar names as well. So some of what you're going to see today is hot off the press, some of our findings from an interview study that we did about a year and a half ago. I suppose we were talking to people, and I just noticed there's a few people who've already put in the chat, oh, I know your name from that. So it's really lovely to see people who are interested and want to know what we find. And a lot of what we're going to talk about today may reflect some of what Karen and Ruth have just talked about, but I suppose just to put in context, this interview study was done kind of last year, 2023 to 2024. So it's a snapshot in time of more recent kind of history. So I think just marking on from Simon's question, I suppose this is a snapshot of the time right now as people provide peer support post-pandemic in the 2020s, so to speak. So I'm going to bring you through some of this, but I'm also alongside the wonderful Lizzie, who's already been introduced. But I wonder, Lizzie, if you want to just wave and say hello to everyone before we get going.
Sure. Hi everyone, I'm Lizzie. Like Andrew and Una said, I work at the PRO as a lived experience researcher, so supporting researchers with their research that they're doing from the lived experience lens. I was particularly interested in peer support because when I was struggling with my mental health as a teenager, I had a peer support worker and that really helped me. And I also trained as one with IMROC a few years ago as well. So kind of got both sides. So yeah, I'll let Una introduce us today and then come back with a bit more.
Amazing. And I want to just put it out there that myself and Lizzie were involved in this study with a number of other colleagues who you will be able to see if we have the link in the chat to our paper, but there are lots more people who have actually done all the hard work in this. So we may be taking the credit today, but thank you to all of our team who actually did all of the hard work and the people that you might have remembered if you did take part in the study. So just some of the little bits of background just before we get going. What we're presenting today is work from the Policy Research Unit in Mental Health, and our views and what we're presenting today are not those of our funders. So do keep that in mind. And also some of these findings haven't been published or peer reviewed. So if you could not share pictures over X or TikTok or whatever the social media is these days, the old dinosaur Una speaking. But if you could keep it just to yourselves, that would be perfect, not to share it too far. But do look at the preprint because it is hot off the press and only came out on Friday. So I'm going to hand over to Lizzie, who's going to start us off.
Sure. So as Karen and Ruth said, a lot of this, so I'll just kind of go through it briefly. Peer support workers are employed to draw on their lived experiences to support mental health service users or carers. So it's got a different approach to clinicians who maybe work through more medical and clinical models. I'd say the training for being a peer support worker was very much about mutuality, reciprocity, really trying to utilize your experience to connect with the other person, which might be different from other approaches. It is recommended in policy guidance internationally. However, it's not that well implemented. It is starting to be rolled out more, which was obviously the purpose of these papers, just to see kind of what's out there at the moment and how we can build on it. But it's sadly not everywhere. There are lots and lots of reviews that have been conducted. However, there's a lack of research exploring the peer support work role itself and the experiences of individual peer support workers, which, as we'll go on to say, were very, very different, both across different services, across different locations. Everyone seemed to have a different experience, and I think that's what this review was really trying to draw out. Really trying to hear the peer support workers' voices to see how that would then affect implementation. So based on that, the aims of the study were simply to develop an understanding of roles and experiences of peer support workers across the wider mental health system, including third sector services. So like we said, it is starting to be rolled out more in the NHS. But prior to this, it was mainly charity-based and those third sector organisations. So we really wanted to kind of get a view of all of them, really, rather than just focusing on the NHS.
Perfect. And as a researcher, I'm going to take on the methods because I like the boring bits, but we'll try to keep this kind of quite low key. So basically what we did is we interviewed peer support workers who were in paid peer support roles across England. As a Northern Irish woman, I recognise that how we do peer support work is important in the developed nations, but there are differences in how kind of policies are laid out. So we thought we'd keep to England, and we talked to 35 people who were in these roles. And thank you to all of those people anywhere here. Thank you so much. There were incredibly rich interviews that were conducted on the most part by our lived experience researchers. I think one or two people were stuck with me, but on the most part, all of these interviews were conducted by our lived experience researchers who have kind of that shared experience of having mental health distress themselves. So that kind of almost peer support, kind of peerness followed through in our research. Most of our participants were from white ethnic backgrounds, most were female, and varied in different ages. As Lizzie's already alluded to, we had quite a lot of differences within kind of our population and also the kind of services people worked in. So 21 of our participants worked in NHS, but we also had people who were working in the third sector and community-based organisations and paid peer support roles, or people who were working on self-employed basis. So a wide range of different experiences, and it came in lots of different kind of experiences and types of people who were involved, including people who were working in kind of low-banded peer support roles up to people who were working managerial roles. So we had a wide range of different types of roles that were also take part. I think you'll hear a little bit more about that with Tasha after us. The type of services that were included, this is what really surprised me and really interested me, was that we had lots of different types of services. So we had not just kind of acute mental health care, but we had kind of people from specialties like eating disorders, maternal mental health, inpatient services, people working in specialist organizations where it was early intervention and psychosis, veterans, student services, everything you can imagine. Peer support is in all of these different services. So we were looking at the barriers and facilitators to all these different things. There's lots of commonality, but there are also some differences. So you will need to look into the paper to see some of those, but we're going to touch on some of our key themes, and I'm going to hand over to Lizzie for that.
Sure. So the themes, there was so much data that came out of them, as you'd expect. And we wanted to try and simplify them. We spent a lot of time going around in circles about how we could organise the themes and how they would look, but eventually we came up with this. So we had, I'll go from bottom to top because for me that makes slightly more sense. So A was the micro level. So this was actually doing the work. So this was starting with the individual and the peer support worker doing the work with the individual service user that they were working with. And here we had 3 different themes, which were striking the balance, having a shared connection with service users, and then being open about your experience and being boundaried. So we'll come on to some of these themes on the next few slides. Secondly was the meso level. So this was working with the organisation. So we kind of saw this as like the middle ground. So not quite with the individual and the service, but the one in between. So in your individual team, in your individual trust. And there were 3 themes there around the importance of good support and supervision, the impact of the wider team, and the kind of ethos of peer support amongst the team you're in and how much that affected the role. And then the heterogeneous nature of the peer support role. So there was a lot of talk around peer support being very ambiguous, people not really knowing what it was, and peers kind of being left to almost define and defend the role for themselves. And then C, we had the macro level. So this was thinking beyond the workplace. So the more systemic factors. So coming into this was things like funding and resources, pay and progression, and the complex mental health systems in general, and kind of peer workers trying to have to find their place in there. So firstly, I'll go back to the micro level. So this was doing the work with the individual, like I said. So participants spoke about the core values and unique elements that made the peer support role different to their non-lived experience colleagues. So it was very much around, they kind of worked to set principles rather than frameworks. So I don't know, CBT therapists maybe have their certain set session structures, whereas peer support was a lot more flexible, using principles, like I said, of mutuality and reciprocity and respect and things like that. And with that created a lot of flexibility. So they could kind of define the role for themselves and define the work that they did with the person. So this could range from, I don't know, doing, sitting in a room and having a chat with them, to really practical stuff like, going shopping, doing cooking, budgeting, all that side of things. They had a lot more freedom to kind of go out in the community and do that practical work as well. Secondly was the unique element of using their lived experience to be a bridge between clinical colleagues and service users. So kind of seeing them as almost like an in-between. So obviously not a service user, not a clinician, but someone who can kind of see it from both sides. And I think that was really valuable both for the individual, having someone who could act like an advocate and understand them, but also for clinical colleagues who maybe hadn't experienced their mental health struggling in whatever field they were working with, say eating disorders. For any clinicians who hadn't had an eating disorder, the peer support workers may be able to kind of explain and develop their understanding in a way that other clinicians might not be able to do. And then thirdly was the personal qualities and considerations needed to deliver this. So a big role around boundaries. Obviously a core part of being a peer support worker is sharing your lived experience, but how much do you share? When is it relevant? What are the kind of parameters around that? And peer support workers really having to navigate that for themselves on an individual basis, and how that could vary a lot between different service users and different mental illnesses as well. Secondly, we have the meso level, so working within the organisation, so thinking about the team that you're working within, and how this was so different. I think it was really recognised that peer support doesn't operate in a vacuum. It's really important to consider the people they're working with, so the other clinicians, other staffs, I guess, knowledge, experience and thoughts around peer support. Really important, the support they receive from managers and colleagues, as well as connections with other team members. I think this varied so widely. We had some interviewees whose services were really good and really advocated for peer support, and it was very much like a top-down approach. And then other people feeling like they were left on their own. No one in their team knew what peer support work was. Their manager didn't really have an understanding of it. They didn't have any supervision, and it was quite a lonely, isolating experience for them. So yeah, the role of the team very much defined how peer support workers felt about their role. And then feeling valued as well was a big one. And maybe people felt like they were there, they were getting paid to be there, but no one really cared about them or their role. They weren't necessarily given a seat at the table for things like ward rounds or care plan reviews or anything like that. And some of them almost felt like sidelined or ostracated from the rest of the team. So yeah, that was that theme. I'll hand over to Una to talk about the wider factors.
And I think the macro level, looking beyond that workplace and the systemic factors, are things that we've already touched on in the review. And it will come as no surprise to anyone who works in peer support and in mental health more widely. It was acknowledged by many participants that while they could be all the facilitators there for actually doing the work and having a great team around them, that often there could be barriers and challenges whenever it came to those kind of more policy-driven things and systemic issues. So things around funding, pay, job instability, lack of career progression came up for the majority of participants. It wasn't always an issue for people. There were some people who we talked to who actually had great career progression or felt that they were paid as an equivalent or that pay wasn't as big an issue. So that it's not universal that everyone is complaining about pay and career progression, but it certainly came up more than it didn't, if that makes sense. And certainly looking at those more structural factors, I suppose using the words that Lizzie used of having a seat at the table when it comes to that policy level and at the more structural side of things. And I guess that's what is really good about this kind of work and being able to present to a lot of people today, is that actually being heard and having a seat at the table to policy people and to those who have the purse strings is really important to show that these are the factors and issues that may assist people so that they can be challenged and looked at better. So in conclusion, what we find is that peer support was highly valued by peer workers, by service users, by staff across a number of mental health services, and that actually there's been an explosion of peer support across a range of services that when I was working in more peer support services 20 years ago, even though I'm sure I don't look at, they didn't exist. Those roles didn't happen kind of 20 years ago for a lot of us. So to see the expansion is incredible, and to see the people who are so passionate and working flexibility with person-centered approaches, but also with boundaries that mean you're not just kind of working in this free-for-all is great. And there are positive cultures out there that we can learn from and see where those barriers and facilitators can help us progress a little bit further, if we say. I'm going to just give back to Lizzie just to give her personal reflections, as she did a lot more of the work than I did. As a final thought.
That is absolutely a lie. I think you did most of the work on this project, especially writing the paper and all the revisions and drafts. But yeah, just some personal reflections. I think I really enjoyed being involved in this project and interviewing the different peer support workers. I think, like I said before, peer support workers don't operate in a vacuum, but sometimes it feels like you do. When I worked in my peer support role, I was the only peer support worker in my team. It was very new. It was very much trying to carve out the role and defend it and justify yourself. And hearing the range of peer support workers' experiences, I think it really highlighted the need for change and kind of the need for it to be taken seriously and for it to be rolled out more, because the impacts were huge. And I think the whole profession relies on the compassion and the passion for peer support workers having their own lived experience and really caring enough to kind of go into it and use that. But that's not going to, be sustainable without the pay and the career progression being reviewed. So yeah, really interesting project. And thank you to Una and everyone else for involving me.
Thank you, Lizzie.
Thanks both. I think we've got a little bit of time for some questions. I noticed there's a question in the chat from Lewis Benjamin. Lewis, I don't know if you want to ask the question.
Yeah. Yeah, no, it's great to see that there was such a variety in the settings that people were working in. But my question was sort of, did you find any sort of notable differences in those working in the NHS compared to in the voluntary sector?
That's a great question, Lewis. We did, and I hope that it comes across in the paper that kind of where we're talking about that flexibility versus having incredibly boundaried work. It felt like there was a little bit of there's a little bit more flexibility in the third sector. Having come from the third sector, I kind of get that, in that you can go and do whatever you want. Your job is your own kind of thing. And people enjoyed that flexibility, but sometimes in the third sector, that was a little bit too flexible, and that the boundaries and structure of the NHS was good in a way, but when it was too structured, sometimes in the NHS, it was too structured. If you have 4 hours to work with these 2 people and that's all you can do kind of thing. So it was that difference between too much flexibility and too much structure, and that both were good, but you need to kind of strike a balance somewhere in that. I don't know if that reflects kind of your experiences, but yeah.
No, thank you so much. Yeah, thank you.
Yeah, I would just add to that as well that I feel like for the people I interviewed, third sector, it was more established. They'd kind of been working there for longer. Peer support was more embedded into the teams, whereas for the ones in the NHS settings that I interviewed, it was newer. And I think that's where they really felt the kind of the understanding and the value of the role wasn't really there. So yeah, I think there was some differences for sure.
Oh, thank you so much, Una and Lizzie. Another great presentation. Thanks for that. So I think we'll move on then to our next presentation. I'm pleased to introduce Natasha. Natasha is a lived experience research fellow at the PRU. She's a peer mentor to students with lived experience and a PhD student at UCL. And she's co-lead author on the Peer Support Ways of Working paper, along with Dr. Ruth Cooper. And I'd also like to introduce Janet. Janet's a long-term carer for someone with severe and enduring mental health issues. She's a carer governor at a local NHS Foundation Trust and a reviewer and care representative with faculties of liaison psychiatry and medical therapies at the Royal College of Psychiatrists, and also manages to squeeze in time as a lived experience researcher at the PRU as well. So welcome Natasha and Janet, and they're going to present on peer support ways of working. Over to you.
So, hi, I'm Natasha. As Andrew mentioned, I'm a lived experience research fellow in the PRU and a PhD student at UCL. Janet, I don't know if you'd like to introduce yourself as well.
I'd say very basically, my main thing is that I'm a carer. I've cared for someone with chronic and severe mental health issues for a long time now. That's my main lived experience, our main focus.
Thank you. Thank you. And so we're going to present our paper now, Understanding the Roles and Experiences of Mental Health Peer Support Workers in England. And I'm one of the co-authors of the paper, and Janet very kindly wrote one of the lived experience commentaries for the paper. So just to show our acknowledgements again, as was shown by Ruth and Lizzie just a minute ago, and by Ruth and Karen earlier. And just to note as well, similarly to the previous paper, our findings have just come out in preprint, so they're not yet in a published peer-reviewed journal. So we do ask, please, if you wouldn't mind not sharing the contents of this presentation, including any photos outside of this session, with very many thanks. Thank you. So just to give an overview of the peer support workstream that we've been speaking about this morning. So we discussed the umbrella review, and this paper is the second qualitative paper that came out of the large qualitative study. And it's about the ways that people are working within peer support. So I'm just going to hand over to Janet now to do a bit background to the research. So thank you so much.
Right, for a long time now, people who use mental health services or care for someone who does have been calling to increase access to peer support in mental health services. Now, there's been a national drive to expand the peer support workforce, and we've seen a rapid increase in peer support across services. But there's still a lack of clarity about what peer support workers do. This is from people working outside of peer support and from some clinicians. There's also limited literature about peer support worker roles and their experiences in mental health services. This creates challenges for guiding local and national policy and future research in peer support. Next slide, please. But the aims of this study were to understand the broad range of roles and experience of peer support workers across the mental health system in England, so that the team could help identify any developments needed to improve their working lives and their ability to use lived experience to the greatest benefit of people using services. Next slide, please. The research questions. The research questions that the paper asked were these. What are the distinctive features of peer support? What values underpin peer support? And what is the impact of peer support? Next slide, please. So what we did, to find this out, we did a qualitative interview study that was co-produced with lived experience researchers with personal experience of using mental health services or caring for someone who does. Participants were people working in paid peer support roles in a range of mental health services across both the NHS and voluntary community and social enterprise sector. All interviewers were lived experience researchers. The team interviewed 35 peer support workers, and some examples of things that are asked in interviews were things like their experiences in teams, what they did in their roles, the impact they felt their role was having in mental health. And after 10 interviews, they did a sense checking event to discuss what peer support workers had told them so far and to see if it was similar for other interviewers. I'm going to hand back to Natasha now.
Thank you so much, Janet. So just moving on to what we did with sort of large collaborative analysis, and I think Fiona and Lizzie spoke a lot about this as well. So just to say the point at which we divided into teams. So everybody initially sort of went through one interview that they'd done with a peer support worker, and then we kind of looked for the sort of main ideas and topics or to overhead themes that were coming out for everybody in that individual interview. And from that, we created a sort of very large group of themes that sort of spoke to us from across the interviews. And that's the point at which we realized there was so much in those interviews that we divided into the teams, with this paper focusing on the roles that peer support workers have, really what they were doing in services and some of the experiences that they were having as well. And we met regularly as a team, sort of to continue to refine those themes as we went along to see what else peer support workers had been telling us within the interviews. So just a reminder, this is the findings sections, which haven't yet been published in a peer-reviewed journal. It's just out in preprint, so thanks very much. It's a reminder to myself as well. So I think Fiona and Lizzie as well spoke about some of the personal information of the peer supporters that we spoke to. So just to speak a bit to add a few more of those, I suppose. So the majority of people we spoke to were under the age of 55. We spoke to more people who identified as being female than as other genders. In terms of ethnicity, there was quite a small number of people who identified as Asian or South Asian, Black African or Black Caribbean. And most people we spoke to identified as being white British or as another white ethnicity. In terms of the peer support roles people were doing, we spoke to more people who were working in sort of standard peer support worker roles rather than as managerial or senior peers. And as Una mentioned, we spoke to slightly more people who were working in the NHS rather than in other sectors that we spoke to people working in those services. And there was about an even split of people doing full and part-time roles. And so we did speak to a lot of people who'd been in their role for less than 1 year. We also spoke to quite a few people who'd been in the role for up to 5 years and a couple of people who'd even been doing it for more than 10. So thank you very much. So in terms of what we found about what we felt were the distinctive features of peer support from what the peer support workers had told us, we found that the individual sessions that people did were very, very adapted to the individual needs of the person they were working with. They were very focused on their recovery and what the person might need, both on that day and over time as well. The support offered was very holistic, so it encompassed both practical and emotional support and really focused on sort of rebuilding those community connections, helping someone to connect with their local community. And also there was great focus on sharing lived experiences. So that was the lived experience of the peer supporter in order as a way to help bring hope through sort of living recovery themselves. But peer supporters were navigating some quite complex boundaries around their own disclosure, sort of disclosing their lived experience in a way that so they did not feel overexposed, but also so their sessions remained focused on that person. And we also found that peers were doing a lot of advocating for people within services. So as we all know, it's still quite difficult for many of us to use mental health services. So peers were really often really trying to make sure that peers that they worked with got the support that they needed or got more support if that's what they wanted. And we found that peer support work was very culturally inclusive, with often the lived experience of peer supporters going beyond mental health to shared other features of identity, such as ethnicity and cultural background. And we also found that many peer support workers were working in a very non-clinical way, sort of not working diagnosis or symptoms, for example, but really focusing on the individual's needs around recovery. Though some peers, there were some tensions between those approaches with more generic clinical roles, with some peers being asked to sort of have a particular cap on the number of sessions they were doing, for example, where that wasn't necessarily wanted, or a change in approach to focus on particular diagnosis or bringing in particular clinical techniques, for example, different kinds of psychological techniques into their roles. But there was also a lot of collaboration with non-peer staff where they were present as well within the same service. And many peers did feel well supported with their teams. There were often lots of opportunities for shared learning also. And in terms of the sort of values that really came out as underpinning those ways of working for us from what peer support workers had told us, and much of peer support was really grounded in a value that recovery is possible, really hope and belief of recovery for those that they were working with and through modelling their own recovery as well. And because of the shared lived experience between peers and people they were supporting, those relationships were really built on empathy with that person's experiences, and that helped develop that true connection as well, which really, really supported the peer relationship. And in terms of being able to adapt the content of sessions really around the individual, this really came across as being centered on person-centered values even, and really being about that person and what they needed. And many peers describe sort of walking alongside somebody within their recovery journey, not trying to fix the person, but really empowering them in terms of making their own choices and helping them along their own recovery journey. And in terms of the impacts of peer support, so peer support workers often spoke to us about the benefits of their own recovery of peer support. They really found that sort of working in a role that they really enjoyed. Many people mentioned that it was the best job they've ever done, and they really got great joy from their profession, and seeing recovery in people they supported was very, very helped their recovery as well. And in terms of there was often quite a difficult emotional impact as well for some peers. For example, if somebody's lived experience was very close to their own experiences, that could be quite a difficult thing for peers to navigate on occasion as well as it being quite an emotionally intensive role also. And in terms of the perceived impact that peers felt they were having as well on people that they supported, they often described people being able to feel more understood and the benefits for recovery as well, as I mentioned. But also, for example, many peers spoke often about the things they had heard within services, about some people being asked to do additional tasks that didn't necessarily fall within the peer support role, and feeling a little bit underprepared for those tasks, maybe not being offered the appropriate training as well. And also, as with many approaches in mental health, many people mentioned that peer support isn't necessarily right for everybody. So, for example, some people mentioned that seeing somebody else with a different experience of recovery could feel quite confronting for them. So it's not necessarily the right approach for absolutely everybody. And there was also some impacts described on the sort of wider care system as well. There was often descriptions of sort of bringing about systemic change, or what came across to us as systemic change, in terms of really promoting peer support across services and helping the development of those peer support services, and really bringing those opportunities for shared learning, elements of good practice, really through that experiential lived experience expertise, which was developed through, having used mental health services themselves, and just having greater insights into the experience of the person and the improvements of practice that could bring. So in terms of the implications of what we found, so the recovery-oriented ways of peer support workers was their ways of working would be very well supported if teams sort of embraced this fully recovery orientated approach. And that sort of is rested on teams having a flexibility and adaptability in order to embrace that good practice and new ways of learning that are risen by peer support works as well. And we did find that although many peer support workers did talk about taking on many additional tasks in addition to the peer support role, that where they were doing this, so this wasn't deterring people necessarily from the profession. But there should be a way, and people often still found great joy in their roles as well, but there should be a way of helping people to be supported to draw boundaries around their own roles to ensure that they are able to keep doing the core of their work, and where sort of additional tasks are seen as beneficial, both by peers themselves, the people receiving peer support, by teams as a whole, understanding as well the great pressure that teams are in as well, that sufficient training is offered as well for people to be able to do those as well, where it's seen as beneficial by all. And what we thought would be helpful for future research into peer support, we thought as well, because one of the benefits of what we did is we looked at a great range of different types of mental health services and sort of different kind of unifying ways of working and values across those approaches. But really doing a bit of survey research could help find out some more specific details about, for example, individual service types, what parts of the role, for example, linked most greatly into job satisfaction for peer support workers, to help understand how they can be best supported within particular kinds of services, but also, and this might also help us find some specific recommendations for individual service types as well. And I think previously it was mentioned around the sort of effectiveness research, seeing sort of how well particular types of peer support that's often developed by research teams, often co-produced as well, those particular types of support. For those, it would be helpful in those kind of studies to use more personalised outcome measures. So we found that in practice, though some people were doing more of that kind of structured peer support, then a lot of people did have kind of open, flexible sessions that were really based around the needs of that person. So having a way where what that person wants and their recovery goals could be measured would be very important in future research also. So yes, so thank you very much. And yeah, huge thanks to the amazing peer support research team and my wonderful colleagues and all the peer support workers and supporters who are involved in the research. And thank you everyone very much for listening as well. I think we have some time for questions, so thank you.
Oh, we do. Thanks, Natasha. Janet. There's some fascinating comments in the chat. Just in terms of questions, I know there was a kind of question, clarification from Adam Downey. Adam, I don't know if you want to ask your question.
I was just wondering if the peer support was just peer support carers, or was it both consumer and carers?
Oh, thank you very much. So it was just consumer in our study.
Okay.
Thank you.
Marja Bergen, do you want to ask your question? So the question is, I founded peer support groups in Canada starting in 2006. Are there such groups happening in England, and how successful are they?
Yeah, it was at a time when churches were ignorant about mental health, really ignorant, and people were being shamed out of their churches. So I founded faith-based support groups for people like that, and it was very popular. We had around 20 at a time to our meetings.
Okay.
I'm wondering whether there are any peer support groups going in England right now, and how successful they are.
Natasha, do you have a view on that?
Yes, thank you so much, and that's wonderful. Thank you so much, and that sounds like a fantastic group to set up as well. So yes, there are peer support groups going on in England as well. We did a previous review about peer support groups, and they were sort of across a range of different countries. But in England, there are some sort of there's some, for example, focusing on the Hearing Voices Network. I know I've used some personally as well in terms of specifically the ones in England and how successful. I'm not sure on an individual basis how successful they are, but there certainly are peer support groups happening, looking at a range of different experiences, for example. So yes, and they can be, I'm not sure in terms of how often they are offered within NHS. There's been quite a lot of peer support groups are offered by the voluntary sector as well. I don't know, Janet, did you want anything to add to this question as well?
Not at the moment, I don't think, no.
Great,
I
thank
know Karen from our team has put a comment in the chat as well, a link that might be helpful. Thank you for that question. We've got time for one more question, I think. Does anyone have a question? Please use the hands function if you do, or add it to the chat. Sonia.
Yeah, it's about social inequality, given that there's a strong link between it and mental distress. It seems to me that peer support workers need quite a sophisticated understanding of equalities in order to be able to support people effectively. Yeah, particularly as a lot of it, you know, you're drawing on people's lived experience and supporting people to get a better understanding of their own experience and their recovery journey as being experts by experience. And I just wondered whether any of that came out in your work.
Yes, thank you so much, Sonia. That's a really, really, really important point. I don't think specifically people spoke. I mean, people had sort of different kinds of experiences with training, for example. I know the barriers and facilitators paper focused on that also a little bit, spoke about training as well. And people had different kind of access to all different kinds of things as well in preparation for the role, but it really varied, both between kind of NHS and sort of voluntary sector, but also just between services in general. I think in the NHS, there's quite a sort of standardized kind of approach to training, for example. But in terms of preparation for the role, it really did vary. So it's not a very helpful answer to your question, but it really did vary quite a lot between individual services, the kind of things that people had access to. And in some services, people had opportunities where there were additional training opportunities that they'd seen, for example, they could embrace those as well. But yeah, I'm not sure if that addresses your question fully.
Well, I just, it seems to me that it's almost like I could ask this question of each of the different pieces of research that we've been talking, people have been talking about, is this issue. It does tend to differentiate peer support workers because they pull from their own lived experience in lots of ways, and because people have to make sense of their lived experience on their recovery journey. It seems like a really obvious area to be exploring is that sophisticated understanding of social inequality. So at some stage, I'm presuming somebody's going to spend a lot of time looking at it, because I think sometimes of the, you know, about the delivering race equality and community development workers and how easily that was swept away. Something that helps to differentiate peer support workers alongside that lived experience. It's a completely different way of relating to people, I think.
No, thank you, Sonia.
The clinical approach.
Yeah, thank you, Sonia. That's a really important insight. Thank you. We now need to move on. Thank you so much, Natasha and Janet. That was another good presentation. Thank you.
So yeah, thank you for those great presentations. So it's now my pleasure to introduce a close collaborator of the Mental Health Policy Research Unit, Andy Bell, who's the Chief Executive at the Centre for Mental Health and has over 25 years experience of working in the voluntary sector to strive for social justice through communicating evidence and influencing mental health policy. And we've invited Andy to, he's been here throughout so far, and we've invited him to give us his reflections on what we've heard and on what the implications might be for policy and for where we go from here. Andy, I can't see you on my screen, but I hope you're here.
I promise I'm here. No, I did just get kicked out and have to come back in again. And I think that's a problem my end with my laptop. So if it happens again, if I suddenly go silent, it's not because I've lost interest. It's because I'll be having a terrible panic trying to rejoin. Hopefully someone will be able to do a kind of a musical number or something while I'm detached. How on earth do you reflect on such a wealth of contributions, both from the studies the conversations and what's been said in the chat. I can't add any more than anyone else here. When you think of the years of experience just among the people on this Zoom call, and the passion and the belief and the understanding, it's quite extraordinary, isn't it? But I will try, because I said I would. And hopefully you know about Centre for Mental Health. If you do, fantastic. If you already follow us and keep an eye on our work, that's wonderful. If you don't, please do look us up and get involved. And we'd love to work with anybody and everybody here who wants to connect with us as an independent charity determined to bring social justice to the mental health space and to bring about greater equality in mental health. So it feels to me like peer support, in a sense, exists in three absolutely crucial areas for improving the mental health system. We first of all know that there is a huge gap in terms of the current workforce. We don't have enough people working in the mental health system in England, probably in other parts of the world too, to be able to meet the levels of need. We currently meet around about a third of need that's out there with mental health services in England. So there is a big workforce gap, and we know particularly in parts of the system there are very high levels of vacancy and sickness among the existing workforce. There's just not enough people to go around. We also know there are real concerns about quality, don't we? That many services, unfortunately, are not meeting people's needs sufficiently, certainly not holistically enough. And there is often a real concern about the quality of care people are getting, and a real opportunity, therefore, to improve upon that. And then, of course, there is an equity gap, and this is the gap that's often forgotten and put to the back of the book, but it's actually fundamentally important to everything. Mental health inequalities are social and economic inequalities. And we have a system at the moment which doesn't treat people equally. And often it's groups of people with the poorest mental health that have the worst access to mental health support, the least good experiences, and the poorest outcomes. So we can turn that around. It's really important we do. And we need to acknowledge the power imbalance. Power is such an important part of our mental health system. The exercise of power is part, unfortunately, of a system that sometimes uses coercion to help people when they need it. So we have to acknowledge those power imbalances and the role of peer support in addressing those. And the exciting thing is, and we've heard this for a number of years, that there is a real opportunity through the development of peer support approaches of many different kinds to shift that culture, to tackle some of those inequities, to provide a bigger workforce, a different workforce, a distinctive workforce, and to ensure more people are getting good quality care and support for their mental health. There are clearly risks, aren't there? And I think we've heard some of those risks today. I think it's clearly been known for some time that if peer support workers are seen as a cheap workforce, as something which is underfunded, not sufficiently paid for, not recognised sufficiently, if there aren't opportunities to build a career, I think the word career has come up a number of times, and it's certainly one of the strongest reflections for me about the importance of career opportunities and structures. There's a real risk that it's not responsive to the diversity of need and to the unequal levels of need among different communities. The patient and carer race equality framework is a fundamentally important piece of mental health policy that's come into being in the last few years. It's clearly important that we take this opportunity to ensure that the peer support workforce really helps to bring about patient and carer race equality framework aims. That's in England, of course. There are similar policies in other areas. That it's not just seen as an add-on to the traditional workforce as something you can expand when you've got a bit of money and then get rid of when you haven't. We all know this happens with anything innovative. You know, the core stays the same, and things like peer support can be seen as a bit of an extra. And indeed, if people's own well-being isn't looked after, I think it's very interesting when we hear about significant risks that people could experience burnout in these roles. In situations where coercion is being used, there's a risk of moral injury, which is an incredibly important issue, often overlooked. And there are clearly worries about being able to fund this sufficiently for as long as it's needed. So how can we make it work better? Well, the knowledge is here in this room, I suspect, among the many people here about how we can really do that together. But clearly, it's fundamentally important we keep learning and adapting. And again, peer-led research is fundamentally important, helping us to do that.
There does have to be a robust commitment to co-design and co-production in the way this happens. Big, long words, often used loosely and without really meaning it. So what does that really mean? It's difficult. If it's not difficult, it's probably not working. That we do have a range of opportunities that allow people to develop their careers and become leaders in this field and be heard within their organisations. I love to point in the chat about how often the peer support workers heard in boardrooms. How visible is that role, and is the voice direct, or is it being mediated by someone else? There's clearly potential for different organisational models, so it may well be different in the statutory sector to the independent and VCSE type organisations. And remember, VCSE isn't one thing. There are some big charities and some very small grassroots organisations, and the ways that they work, their framing of things can be very different to one another. And there may well be differences in different settings, mightn't there? What this looks and feels like in an inpatient setting might be different to the community, or in primary care, or in supporting people in physical health settings. Remember, people with severe mental illness have a life expectancy that's 15 to 20 years shorter than it should be. So what's the opportunity for peer support to help to address some of those physical health inequalities and injustices that we observe? And then we talked a bit about, I heard a bit about advocacy. And again, that's a quite different thing. Independent mental health advocacy is a legal framework, a legal service. But there may well be overlaps in peer support workers become advocates, and advocates may become peer support workers. Maybe that's okay. But maybe we need to understand that better. We need to make sure we're really being clear who's being employed to do what in what way. So there are opportunities in the policy world. There is a long-term workforce plan for the health workforce in England. It's likely that will be reviewed at some point and we'll have something new. The Labour government that came into power here in the UK last year pledged 8,500 more mental health workers. Hooray! Now that would actually be a slowing down of the rate of increase in recent years. So we need to be very careful what we're hurrahing here. But how many of those can and should be peer support workers, and how would they fit alongside others? There's a real opportunity here. Let's hope we can get it right. There's so much more I could reflect on, but I'm not going to, because it's time to listen to other people. But thanks so much for allowing me to be part of this conversation today.
Great. Thank you very much, Andy. Those are lots and lots of food for thought in those reflections. So first of all, I'm very pleased to introduce Professor Steve Gillard, who's worked with us quite a bit at the Policy Research Unit, but also leads an internationally recognised research programme that's had NIHR funding on peer support in mental health services. And he's a professor at the newly formed City and St George's University, which is part of the University of London. So thank you very much indeed, Steve, for agreeing to contribute this afternoon.
Great to see so many people on the call. Lots of names that I recognise and some people who I haven't seen for a long time. So nice to see you all. A number of the team who took part in this study are also on the call. We were quite a large team, and lots of peer workers and survivor researchers were involved in developing and doing the research with us. And my final slide will acknowledge all those people. So you're going to get more implementation from me. I'm going to talk about an implementation study that took place alongside a trial of peer support. So what we wanted to do that hopefully is a little bit different from some of the other implementation studies we've heard about is we really wanted to explore whether there was a relationship between the effects of peer support and how it was implemented. So I'll tell you in a second how we went about doing that. The trial was the Enrich study. We actually finished this a few years ago, but as is often the way with these things, we only recently got round to doing the implementation piece, and that and this project was published at the end of the back end of last year. So this is a fairly new piece of research. I'm not going to talk much about the trial itself. We we co-produced a training program and a peer support handbook that was around supporting people with the experience of discharge from inpatient to community mental health care. So people began their peer support while they were still on the ward, and that continued for about 4 months after discharge. Unfortunately, we found no overall effect of peer support on outcomes. So that's for all the people who were offered peer support. But if we look at those people who received a minimum amount of peer support, and we're talking quite a small amount here. So there's people who received at least 2 sessions, at least one of which was in the community after discharge. So not if people had kind of multiple sessions while they're on the ward, but if they chose to continue to meet with their peer worker after discharge, if we looked at that group of people, they were less likely to be readmitted to hospital in the year post-discharge than a similar group of people who weren't offered peer support. So there was an effect for those people. And what we wanted to know in our implementation study was why some people felt able to engage with more peer support and therefore experience better outcomes. And if the way in which peer support was implemented made a difference to that engagement. So was there a relationship between variation in implementation and outcome? Just a couple things about the study before we get on to that. As I said, we co-produced our training, and that process was informed by what we call a principles framework that we developed with an expert panel of people who were doing and leading peer support and working in peer-led organizations and so on. And the idea behind the principles framework was that it asked, what are the principles that need to be in place to make sure that all that's kind of important and distinctive and valuable about peer support when it happens kind of naturally in the real world, that makes sure that gets implemented into practice when peer support moves into mental health services. So this framework kind of underpinned the development of our peer support. And what we did next is we developed what we called a Fidelity Index. So this is really a set of interviews that was designed to test the extent to which those principles were implemented into practice. And we used that in our implementation study. So what we wanted to do in the implementation study was to evaluate if and how that fidelity to peer support principles was associated with the level of engagement with peer support, and therefore by implication with whether it worked or not. So we had 2 questions in our implementation study. So the first was, is there any relationship between level of engagement and fidelity score at each site? And the second question, if there is, how was peer support implemented at sites with different levels of engagement and fidelity? And was there a difference in implementation that might explain that? And this is how we asked our first question. So in this graphic here, the blue dots, the 7 blue dots there, and those are our different sites where the trial took place. Those are 7 different NHS trusts in England. And the scale on the left is our fidelity score. So it's a score up to 12 that measures fidelity to peer support principles. And the scale along the bottom is the percentage of people who were offered peer support who engaged with that minimum level of peer support, who basically decided to continue to meet their peer worker after discharge. And we can see that there does appear to be some relationship there. So in the top right there, sites 3 and 5, around 80% of people who were offered peer support chose to stay engaged, and those sites had a fidelity score of around 11. And then in the bottom left there, we've got a couple of sites where engagement was around 30–40% and fidelity score was much lower, and the other sites are there somewhere in the middle. So there does appear to be a relationship between fidelity to peer support principles and levels of engagement with the peer support. So we proceeded with the implementation study on that basis, and we used what we called a comparative case study design. So what we did is we compared those two sites with high engagement and high fidelity, the two sites with low fidelity and low engagement, and also what we called our outlier site. So there was one site in the middle then, site 2, that had a high fidelity score, but engagement was somewhere in the middle. So we wanted to explore what might be going on there too. And the data we used for this were interviews with peer workers and their coordinators at each of those 5 sites. So that was 20 peer workers, between 2 and 5 at each site. We interviewed 32 peer workers for the study as a whole, but we just focused on those in the 5 sites we chose for this piece of work, and their 5 peer worker coordinators. And the way we analysed that data was, first of all, to code it to an implementation framework, a different one to the one that Ruth and Karen used. We used the Paris framework, so that framework, based on other research, tells us what might be some of the important issues around implementation. We adapted it to foreground the role of lived experience and experiential knowledge in producing evidence that informs new innovations in healthcare and how that's implemented. And then we did what we call pattern matching with that data, so that we could explore similarities in implementation across all of the sites and differences in implementation between our high and low engagement and fidelity sites. And this is what the data told us. So first of all, looking at similarities across all 5 of our sites, we found consistent delivery of our training, and that training from peer workers' perspective supported them in the skills that they needed. So they talked about doing a lot of strengths-based approaches, active listening, discussing difficult issues, working with boundaries and relationships. We also saw the importance of groups of supervision, which was facilitated by an experienced peer worker coordinator, supplemented with one-to-one supervision. And there's a quote here from a peer worker talking about what they got out of group supervision and sharing with their fellow peers. And there's other quotes where people talked about the one-to-one support with a supervisor who had been a peer worker themselves and brought that lived experience to the supervision role. But there was also data about a lack of contact between peer workers and community mental health teams, and the lack of understanding of the peer worker role and how that could be really challenging and disruptive of the peer support. When we looked at our 2 high engagement, high fidelity sites, one of the things that came out that was really important was the work that peer workers and their coordinators did preparing the clinical teams before they started to deliver peer support, and that was specified in the handbook, and how that, as a result, peer support was really valued by inpatient teams at those 2 sites. And in particular here, they talked about going back in and doing those sessions again when there was staff turnover, and that the wards were a kind of welcoming place for them. The peer worker coordinators, the supervisors, talked about being well-resourced, so that they had sufficient time for their role, and also they had regular supportive supervision themselves. And we found in these 2 sites that delivery of peer support was very consistent with the manual, especially around things like relationship building and pacing of peer support, working alongside someone, being flexible in the approach, and so on. So that was our high fidelity, high engagement sites. There was a different picture in the 2 low engagement, low fidelity sites. It's perhaps worth noting here that in those 2 sites, the peer support was provided in the voluntary sector by organisations that were kind of subcontracted by the NHS to provide the peer support into their wards and community teams. We were really surprised at this finding because our other research said that those kind of partnership arrangements were really effective around bringing a culture of mutual support, positive risk-taking, very individualized approaches to support, bringing that into the NHS context. So we were really surprised by this finding and wanted to properly understand it. One of the things we found, in contrast to the high fidelity sites, was a lack of resource for peer worker coordinators. So a lack of time for them, a lack of cover for their time. We had peer worker coordinators saying that they felt they had to go into work sick because there was no cover for them. They didn't get supervision from people who understood the role, and they also didn't get funding to attend the study-wide support network we had for peer worker coordinators. They also talked about issues of access and authority into the NHS, that they couldn't get on the crucial meetings, they couldn't get to talk to people they needed to kind of make sure the peer support was delivered in the way that it was attended to. And there were inconsistencies in delivery of training and supervision. Some of those were down to geography. Coincidentally, these were our two sites. One of them was in a rural area, and the other was in a kind of large town with a large kind of suburban outreach into the countryside. And that really disrupted being able to bring the peer worker together and build a sense of team. And we saw a lack of confidence from among the peer workers in delivering the peer support as it was described in the manual. So peer worker talking here about feeling that they were getting it all wrong, and a sense of, well, isn't this what I'm supposed to do? But it was not really working. And there were 2 or 3 quotes of this nature that we actually didn't see in the high fidelity sites. In our outlier site, where fidelity was high but engagement was low, we found some similarities with the 2 high fidelity sites. So again, there was that strong, confident delivery of peer support as it was envisaged in the training, around building a rapport and providing a safe environment and building trust and so on. But that seemed to be undermined by challenging relationships with the ward staff, so a lack of understanding of the peer support role. So that kind of building around a shared sense of culture hadn't been able to happen there. And there was also a lack of support and resourcing for the peer worker coordinator in that site. So they felt they needed more support, more training, more supervision around managing people with lived experience. So what did we think were the implications of this for introducing peer support into mental health services? So as has already been mentioned by Andy and others, that there's a plan now for employing thousands of more peer support workers into mental health trusts in the coming year. What our study suggested in that context is that training programs need to equip peer workers to feel confident around relationship and build and so on, to kind of deliver peer support in line with the values. I mean, we know that that's in the other implementation literature, but our research suggests that there is a relationship between this and the effects of peer support. And if the plan is to roll this out at scale and pace, you know, there are new training programs have been commissioned by NHSE recently to do that. Is this training of this sort going to be protected? Again, around group and individual supervision, the importance of that, and that peer worker coordinators and supervisors themselves are sufficiently well resourced and trained. We were lucky to have people in our study who had that skill set, but what's the career progression and the training in lived experience leadership to ensure that that's in place? The importance of building a supportive sense of peer worker team was absolutely crucial in our study, and did seem to relate quite strongly to the impact of the peer support. Obviously, there were challenges of geography in a couple of our sites. In our study, our peer workers were all based together in a single team, but we know that the picture usually is that peer workers are spread out across the MDT. So what support is there for that sense of peer workers being part of a larger lived experience team? Clearly, change work and peer leadership in that was still needed to address issues of culture and understanding of peer support across clinical teams. The experiences of peer workers in our study were very, very different in sites where that was in place and in sites where there were challenges around that. And then we had a question earlier around peer support in the voluntary sector, and we found that there were real issues of access, authority and resourcing that needed to be addressed where peer support is provided by third sector partners. So hopefully that's some insight from our study into the relationship between how peer support might be implemented and the key things that really might affect outcomes and the experience of peer support. This is the study as a whole, and there's a link there on the bottom, and that's the team that took part. I should also say this was funded by NIHR, and I forgot to do the disclaimer bit. So just to quickly say that this was independent research and it isn't the views of NIHR or the Department of Health and Social Care. There, I've done that bit. Thank you.
Brilliant. Thank you very much, Steve. That's highly interesting. We actually don't really have time for questions at this point. So if you'd like to, Steve will be returning anyway in the final discussion, but if you'd like to ask any questions, please post them in the chat and Steve maybe can have a look what's there. By the way, I do congratulate everybody on the quality of the discussion in the chat. I think this is one of the better Zoom chats I've ever read. So thank you for that. There's lots of highly interesting contributions. Okay, so it's my pleasure to introduce our final speaker, who's Professor Fiona Lobban, who's joining us from Lancaster. She's a clinical psychologist and she's a leader in developing and researching innovative psychosocial interventions, including involving peer-to-peer interaction. And she's going to add something new by, I think, taking us into the online world and thinking about how that works in peer support. So thank you very much for joining us, Fee.
So thank you very much for inviting me. I'm really delighted to be here. And it's been so nice to hear everybody's talks so far and to read the chat. I'm going to talk about the iPOF study, which is a study which aims to improve peer online forums in mental health. So just to get in with the disclaimer, this project is funded by the National Institute for Health and Social Care. So the views expressed are those of the authors and not necessarily the NIHR or Department of Health and Social Care. Just to highlight also that the host NHS organisation for this was Berkshire NHS Trust and the sponsor was Lancaster University. And this diagram just gives you a list of all the lots and lots of people involved. I'm not going to go through them all, other than to flag Karen Machin, who's just done a talk. So she led our co-design, PPI and co-design group, and Steve Gillard, who very kindly chaired our trial steering committee in a very supportive fashion. So thank you both. So just to give you a bit of rationale for this, so online forums are widely used across all health, and they're particularly valuable for people who experience stigmatized conditions. So this is across physical and mental health. And I guess they're attractive partly because they're free to access generally. They're available 24/7. They are asynchronous, which is particularly attractive to people from different neurodiverse backgrounds. They're generally anonymous and they're very easily accessible. So people in rural communities, etc., it doesn't involve traveling long distances to seek help. Forums are generally text-based, although increasingly using emojis and other kinds of communication. And there's lots of variation. So we've talked a little bit about peer support. Actually, even within online forums, there's huge variation in how they're designed, who hosts them, how big. Okay, so I guess the evidence for the impact of peer online forums is fairly sparse. And there's quite a lot of anecdotal discussion about this. So some of the more positive things that people report are that they can be very normalizing, validating, connect people. But also there was some quite high profile reports in the media about people being distressed or discouraged using online forums, and some of the content being quite overwhelming. And the reason that we were really interested in doing this study was actually we ran a web-based support for relatives of people with psychosis, which had embedded in it a peer online forum. And actually, the qualitative feedback in that study was how valuable that connection was. And it also came from one of our service user researchers who'd worked as a supporter on a peer online forum and actually had a very negative experience where she had not felt supported, not been cared for, and actually it made her quite unwell. So we were really interested in this kind of mix of positive and negative impacts. So I guess the unanswered questions that we were curious about were, should we be using online forums to support our own mental health? And if so, which ones from the whole array of things that are available? Should we be referring people to them if you're working in a clinical context? And from a policy position, should we be funding them? And should organisations like NHS trusts and charities and other voluntary sector organisations actually host them? So we were keen to do this, but we realised that randomised controlled trials, which are often promoted as the kind of gold standard of evaluation, are not really appropriate, partly because the forums are already out there and they're already happening. So randomising people is really, really difficult. And also that we already anticipated that different forums would have different impacts for different people. And we didn't want to control for that in a randomised trial. We wanted to actually explore that variability. Can I have the next slide, please? So we used an approach called a realist approach. And I won't go into the detail of this, but essentially, rather than asking, does intervention X work better than intervention Y, and kind of getting a yes or no answer, the realist approach builds a program theory about what are likely to be the impacts and why, and for different groups of people, and then works to test that theory. So it's really good for real world interventions which are already happening and for which there's likely to be variation in response. So our three main questions were, what are the impacts of using online mental health communities for people experiencing mental health difficulties? How, why, and in what contexts and for whom are these impacts generated? Our second question was, what are the roles of community moderators and how do they impact online mental health communities and are impacted by, in fact? And in research, the third question was, how can we use the theories that we generate about how online communities work to inform best practice guidance and support so that this had real world implications for people hosting forums or commissioning forums? Next slide, please. Thanks. So this was the design of the study. There's a lot of detail on this slide, but essentially what you need to take from it is there was 3 stages. So in work stream 1, we built our theories, and we did that by doing a review of all the literature around peer online forums. We carried out interviews with people who were hosting and moderating online forums, and we drew on some middle range theories. So these are kind of formal theories that exist about likely mechanisms, and the 2 that really turned out to be useful were around psychological safety and self-determination theory. So once we built our theories about how we understood forums would work, we then tested these theories, and we recruited 7 mental health online forums across the UK, and we ran 3 different data collection programs. So one was quantitative surveys, where we asked people, we tried to ask as many people as we could in the forums to fill out a questionnaire that asked them about their experiences. We then did some very detailed qualitative interviews with the users of the forums. And we also did some linguistic analysis of some of the forum posts that were actually in the forums. And each of these methods has different pros and cons. And the aim was to triangulate the findings from each method to try to learn the most that we could about how forums worked. And then our third work stream was the PPI co-design group, which was led by Karen. And this group met over the whole 2 years. There was 22 sessions, and it had 23 participants with lived experience in it. And their task was to co-design the key materials that came out of the study. Next slide, please. This is just a nod to highlight that one of the really interesting things that came out of this study were the ethical and practical challenges about collecting data in online environments. And I'm very happy to talk about those in detail if anyone's interested, but it's not the main focus here, but particularly around things like anonymity, diversity of participation, and consent. So one of the key things that is about this is about anonymity. And so we really wanted to not only keep the identity of our individual participants anonymous, but we also wanted to not identify the forums that the data was coming from, because once you identify a forum, particularly on smaller forums, then you increase the likelihood of identifying individuals. So we ended up giving each of the forums a bird name, and then we did a sort of case study description of each one so that the contextual variation of them is maintained, but without identifying the forums. Next slide, please. All of these are on the website as well, so if you want to look at this in more detail. So for the first question, we were looking at the impacts. And first of all, I'm going to give you the sort of final outcome theories, and these are still being refined and still being developed. So this is our best kind of version at the moment, but in realist approaches, you're constantly iterating and refining your theories. So these are some of the theories where we're up to around some of the positive impacts. So they're written in this style of CMO, which is a context, mechanism, outcome statement. And what it tries to do is highlight what contextual factors are important to trigger the mechanism that then generates the important outcome. So I've highlighted the important outcome in red and the mechanism is in purple. So this is really trying to get underneath what is actually happening in the forum that generates these important outcomes. So the first one is in well-populated and active forums that are clearly organized to allow users to find posts and receive responses that are personally relevant, users will be more likely to identify credible and actionable information that they can use to better manage their mental health, promoting mental health self-efficacy. And then the second one, when users feel safe to share their mental health experiences with others whom they perceive to be non-judgmental as having relevant experiences, they will use the forum to reflect on their circumstances and integrate others' perspectives into their own, resulting in novel and more hopeful ways of making sense of their mental health experiences. And then the second sort of broad theory area was around social connection. So again, when forums bring people with similar experiences together, users have access to posts that resonate with their circumstances. This normalizes their mental health experience and validates their own reaction to similar situations. This can reduce self-stigma and provide a sense of belonging. Users who share their personal experiences on the web derive satisfaction and a sense of purpose from the knowledge that their posts help others, particularly when others express gratitude. So this really taps into the reciprocity of peer support. So it's not only people are finding stuff that's useful for them, but they're really getting a lot out of helping other people. When forum users post messages and receive timely, constructive, and empathic responses from other users, they will feel recognized and understood. This will contribute to a sense of connection with the online community, increasing forum engagement. Okay, and then the third and final positive impacts area that we're exploring and developing at the moment is around this relief and catharsis. And this wasn't as prevalent in the data set, but it did come out as really significant for some people. So when people are truly anonymous in the forum and can control the responses that they invite from others, they feel safe enough to post about their most challenging experiences in the forum. The process of writing externalizes the experience onto the page and helps them see their experiences from a different perspective or distance, fundamentally changing the way they understand their experiences. And the interesting thing about this is this can happen without any response required and seemed to be particularly important for people who needed to disclose things that they couldn't talk to family and friends around. One thing just to really flag is that the majority of people in online forums never post. So you really need to explore the impacts of both posting and not. And then the negative impacts that, just to highlight, are for users making an original post, especially when feeling particularly low or vulnerable, the removal or editing of the post by moderators, or absence of a response or responses unrelated to the post, can prompt feelings of being rejected, ignored, or misunderstood. This leads to increased self-stigma and sense of isolation and reduces forum engagement. And when users read about difficult experiences, they empathize and want the person to receive help quickly. This increases their sense of responsibility for the well-being of users, which can negatively impact their well-being. This is less likely to happen when they're confident in speedy responses from the moderator. Okay, so in terms of moderators, there was loads of data on this, but I'm just going to give you two possible mechanisms that are coming out. So if moderators are motivated to support others, perhaps due to similar previous experience, then they feel a sense of accomplishment and satisfaction from seeing supportive communication and success stories on the forum, because they interpret this as evidence that their work has been beneficial in supporting forum users' well-being. And moderators are often exposed to distressing content. Being able to draw on a team with diverse skills and experience increases moderator competence to respond, because they don't feel solely responsible for user well-being and feel more supported to provide a collaborative response. Next slide, please. So these theories are still being developed, as I've said, and throughout the project have iterated, but throughout have also been used to guide our development of some best practice guidance and tools. So there's going to be an animation about why forums might be useful and why it's useful for services to think about forums. We've developed an e-learning toolkit for moderators, some best practice guidance for people who want to design a forum and to train and support moderators, and to try to set up a community of practice to bring together people who are involved in forums. Next slide, please. And this was just a lovely visual that Grace Collins, who works with Karen, produced for us, that just captured what was included in the forum moderator training. Next slide, please. And I guess just to highlight what's in the best practice guidance. So for forum designs, it's particularly focusing on how we keep people safe, how we generate a sense of autonomy in people's ability to use the forum, their competence to do that, and how to keep people related to each other, so supporting meaningful connection. And for moderators, it's really about clarifying what the role is and allowing moderators to be flexible in how they execute that role, very much about supporting their well-being and about how they're managed and trained so that they feel part of a team and don't feel an overly individual sense of responsibility. Next slide, please. So I guess some of the conclusions that are, I just wanted to flag. The first thing I think is realist evaluation, I think, is a really good way to evaluate peer support kind of interventions, precisely because of the things that have been talked about so far. So it's not one kind of intervention. It's not a drug like you can use in a randomized controlled trial. It's actually lots of different things. And also those things, the way they're implemented, as Steve's flagged, depends very much on the context in which they're being used, and they'll have very different impacts in different contexts, and also for different people. So you really need the flexibility of that kind of evaluation approach. The implementation gap is a big issue that we haven't talked about so much, and it was particularly evident in this study, which we can come back to maybe in the discussion. The impacts of forums were largely very, very positive, and people literally call them lifesavers. But we do also need to understand and manage the negative impacts that can happen for users and moderators, as with any kind of intervention. And I think the design of forums and how they're moderated, it's not going to be one size fits all. So I think the idea of trying to come up with this is the one way to do it is a really bad idea. And actually having lots of different models and lots of different ways this could go will help to understand what those core components are. And I guess finally, just to flag that there's so many different roles for forums. And if we think about where they fit in the sort of menu of support that people can access, I mean, first of all, they are very accessible, which makes them incredibly useful and puts them in a good place currently in services. But from a public health point of view, they can really facilitate supporting well-being and mental health from people who aren't seeking mental health services. But they're also great for the lots and lots of people on waiting lists, because they can support people just to better understand their experiences, to connect, and maybe start to reduce some of the stigma that many people come into services with. And I think in terms of ongoing connection as well, for maybe people who've been through, pieces of work, or therapy, or whatever the intervention is, actually coming together and staying in contact with folk and having that ongoing support is often something that I think we miss in mental health services. So thank you very much. I hope that was interesting.
Brilliant. It was extremely interesting, and also very interesting to see you use so effectively realist evaluation methods, which I think is both highly promising and highly challenging, isn't it, as you've suggested. So no time for immediate questions from that, but Fiona's staying with us, and I'll hand over to Andrew again for a final discussion. Thank you.
Yes, thank you. So for our concluding panel discussion, I'd like to introduce Hannah. Hannah's a lived experience research fellow at UCL with a special interest in peer support in eating disorder settings, and she's previously worked with the National Collaborating Centre for Mental Health and Health Education England on the competency framework for peer support workers. I'd like to introduce Mark. He's one of our lived experience researchers in the PRU and co-wrote a lived experience commentary on one of our papers. Raza is also a lived experience researcher with the PRU. He coordinated a peer support group called Kindred Minds and wrote a manifesto document entitled A Call for Social Justice, a manifesto for change by and for mental health service users from racialised communities. And I'd like to welcome back Steve and Fiona. Thank you for agreeing to be part of our expert panel. We've got an opening question just to get things going. So I'm going to ask each of you, what do you think should be the priorities for peer support in England over the next 5 years? Who wants to take that first?
I'm happy to.
Thanks, Raza.
Hello, so thank you very much. So I don't know if I'm an expert, but I certainly have some, experience of peer support. So the first thing that I want to say is it feels like, the lie of the land is constantly changing. These forces outside our control are constantly changing the lie of the land. And then we're being asked, well, what colour should the garden path tiles be? Because these changes that have happened whereby there was so much peer support, service user led, and also in the independent sector, it really has been decimated, because of austerity and various other things. And we didn't make that decision. That decision was kind of made for us. And not only are we being asked what the colour the garden path tile should be, but I'm not quite sure where the garden path is leading. But anyway, there's a little caveat. So I have some thoughts about what needs to happen. So I have a little preface. Do I have like 2 or 3 minutes, Andy, or how long do I have?
2 minutes would be great.
2 minutes, okay. So the first thing, more funding for service user-led and independent peer support. Funding criteria need to facilitate this development rather than being wedded to other agendas which create, endless hoops that groups need to jump through. Secondly, there needs to be, within service land, there needs to be better support for peer support workers who are doing a very difficult job, within mainstream services. So in terms of line management, which should be by other peer support workers, the training career development path needs to enable them to move beyond bands 3 and 4. They need to have higher pay. And arguably, I don't know about this, but arguably, this is a question, does there need to be a professional body for peer support workers so that the profession can be championed? But I think there is an inherent tension, you know, between standardization and the flexibility required of peer support. And then finally, there needs to be more research into the value of peer support in different settings, particularly taking consideration of what makes an effective peer. Is it just about, you know, having a mental health experiences, or does it also relate to demographic characteristics and life experiences? For example, if you're a war veteran. And also, how can we replicate, you know, the leveraging of the strengths and experiences within communities? Because peer support used to not just be this kind of one-to-one relationship, but it was about leveraging the experiences, the knowledge, the wisdom within groups of people, you know? And how on earth can you replicate that with a peer support worker? I think, you know, the peer support worker can do some of what peer support could do, but it's a kind of a subset, and possibly a reduced subset. So anyway, that's just a little.
No, thanks, Rob. Thanks for getting the ball rolling on that one. Any other member of the panel want to comment on priorities for peer support over the next 5 years?
I'm happy to be again.
Oh, yeah, go on, Hannah.
Is that all right? Brilliant. Thank you, Andrew. So firstly, just a massive thank you to all of our speakers this afternoon, because I found it so thought-provoking and I have so many ideas whizzing around. I've not yet got a beautiful metaphor like Raza has with a garden or anything like that, but I have tried to boil down what I'm thinking into just a couple of points in terms of where we could see peer support going in the next few years. I guess if we were to look forwards, I'd probably highlight what you said at the very beginning of this session, Andrew, about that contention between formalising roles and diluting the essence of peer support. And I know, Raza, you just reiterated the same point. Now, I think a way we could maybe explore doing this is, instead of having these two camps of the more formal roles in statutory services or the more organic peer support roles, is there a future where they can work together and complement each other and be more synergized? So instead of either or, we're looking at yes and. Because, you know, I was hearing when we were doing our introductions at the beginning, someone mentioning that they had a heavy metal peer support group. And I'm like, we can't not have forums like that to exist. But I don't think, you know, the investment in the formalisation of these roles in statutory services, where we've got policy directives saying we need X thousand number of peer support workers by this year, that should be at the expense of these grassroots organisations. So a world where we see what we need to happen in these statutory services, like the consistency across roles, both in terms of remit and scope and supervision and training and progression pathways, but also making sure our voluntary sector colleagues aren't left out. And I think just finally, because anyone who knows me knows I can't talk about peer support without mentioning eating disorders, I think there is a second thought of mine where I'm thinking, how can we be supporting peer workers across these different specialist settings? A lot of the talks we've heard today have really emphasised how we're seeing peer support work, not just in, you know, your community mental health service, but in your specialist eating disorder, autism, perinatal settings. And is there a way we can maintain, you know, is there a way that these roles can still speak to the nuances of these different experiences, again, without losing the importance of a standardised approach? And I think those are all my thoughts for now.
Thanks, Hannah. Any other member of the panel wants to come in on this one?
Yeah. Hi, I'm Mark, everyone. I've had a diagnosis of bipolar disorder for the last 30 years. And for the last 12 years, I've done lived experience research roles. I just wanted to say that I welcome everything that people have said today. It just strikes me that we need to, you know, think of the individuals and how we can support them. And whilst I think there's a need for more peer support workers and a rolling out of training programs to make sure people are competent and doing a great job, I think what shouldn't be overlooked is rural communities, because I can see there being an increase of peer support workers in cities, in big towns. But what about people like myself who live in rural communities, and there's maybe only a few, 1,200 people or 750 people live in that. So I think I'd like to see a rollout of more peer support workers across the country, particularly in rural areas.
Hey, thanks, Mark. So let's move to another question. Annabelle, do you have a question for the panel?
Yeah, sorry, I put my hand up because I didn't
Yeah,
know if
go
there was other
for it.
people. I think because I've kind of come from like a clinical perspective, so I'm a nurse by background, but I've got a lot of family members that are under services, so there's been a lot of lived experience, but in a different perspective. But in my last team, we did have peer support workers, but it felt like their opinions weren't necessarily acknowledged by the clinical team. It was kind of like, oh well, it was almost seen as, I don't know. And it's how can we get it so that like clinical teams actually get that person involved in, say, like when you're creating a care plan with someone, just any intervention that can be done. Because I mean, I used to approach peer support workers and be like, listen, I'm going to have like a difficult conversation with a patient. I'm going to see them because of whatever was happening in that person's life. So I'd ask, is there anything that you would hope, is there anything that I can do that can make this conversation a little bit easier? Do you know what I mean? So it's because it's almost seen as like an extra, like a tick box. Oh, well, we've got a peer support worker in the team, but I don't think it's always, the importance of it is always acknowledged. I mean, I was having this conversation this morning, so it's just kind of, how do we make it more where people actually want there to be involved, rather than it just being oh, well, we've got one, so you can do your own thing and we'll do ours.
Yeah, no, thanks, Annabelle. That's a great question. Who from the panel would like to respond? Hannah?
Yeah, I think firstly, Annabelle, like, thank you for sharing those experiences, because unfortunately, I don't think your experiences are isolated. I think that does happen in many services, but I saw something quite wonderful in the chat this afternoon where somebody from a NHS trust was, asking for advice because their peer support strategy was quite underdeveloped compared to maybe other trusts. And I think that's definitely a way forward, trust sharing good practice and how those sorts of issues have been navigated, because I'm sure, as well as your experiences, there are trusts who are embedding peer support workers in multidisciplinary teams and doing that really well. And there needs to be a way for that to be communicated to workplaces like your own. So yeah.
Thanks, Hannah. Thanks. Fiona?
I just think there's something about how do you, we talked a bit about power and professionalization, and there's something about how do you bring peer support workers or peer workers, they're not always in that PSW role, but together to have a stronger voice, to have, guidelines about what support's needed, but without the downside of professionalizing a role in some of the ways that other professions have been professionalized. And I think that's a really interesting piece of work, because while there's one peer, someone was talking about being the only peer support worker in an organization. I mean, that's just a really miserable experience, and you don't have the power to change anything. But I think when you bring people together and you have that support of your community behind you, then you can make real change. So it's kind of, how do we do that?
And that's the thing, it's like, because there'd be some practitioners that are really into, let's get this peer support worker involved, because there's this piece of work that can be done that can be really meaningful for someone. But I don't know what it is. I don't even know. I don't know if it's a cultural thing where within certain workplaces it's not as seen as valued, or like, but it's like also like, I don't know, support workers, for example, it's almost seen as, unless you've got a professional body, oh well, we'll ask you a bit, but not. I don't know how to explain it. I remember getting really frustrated because all the peer support workers in our team, anyone that they were working with me with a service user, or just, it was so easy to get that person involved and get that insight, but yet other people just didn't seem to, I don't know, just didn't seem to utilize it and make the most of it.
Fiona, was that kind of a final word?
Can I just add one little thing to the point made earlier? So I have heard this in an organisation where someone said, but peer support doesn't work. And it made me think how careful we have to be as researchers, that we start to really think about what impacts and outcomes we're measuring in research. Because if we get that wrong, which I think, you know, a lot of people have talked about, clinical outcomes are not the things that actually necessarily are going to be what changes. And I think if we do studies where we're measuring clinical outcomes and actually missing the things that are so valuable, there is a real danger that we create an evidence base that suggests it doesn't work, which I think.
Yeah, but I think that's like people, I don't know, you know, that really old school way of thinking where, I mean, I've had like family members that have studied nursing in decades gone by due to like family experience. And they were told like kind of, oh, well, you're only doing this to try and fix yourself. So that like there's still people in clinical settings that view it as it's not, you shouldn't, not that you shouldn't be in the role, but it's kind of, you have to have a separation to be an effective practitioner. And I think this is why if we were to get peer support really utilised effectively, you know, there's more evidence to say that lived experience makes a massive difference. But I think getting people to be confident to actually, I don't know, involve that. Sorry, I'm like going on.
No, that's fine.
I remember there was a lot of frustrations in my previous service where I'm like, what are you doing? Why are you not? I don't know. So I'd.
No, thank you. Really, really important points there. Thank you, panel, for a really helpful discussion on those points. We are almost at time. So I want to thank all of our presenters for some fantastic presentations this afternoon. Big thank to Kirsten Anstey, our administrator, who's done so much behind the scenes, and to Andre Tomlin, the mental health, for all of his support this afternoon. And thank you to you all for coming along and engaging. I mean, the chat has been fantastic. Reminder, if you do want to think more about peer support and talk more about peer support, we've got our mental health question time event next Monday evening, Monday 27th in the evening. That's an in-person event. Do come along to that if you can. Thank you so much, everyone, for your time this afternoon. All the best. Thanks. Bye.